Hi everyone. Today the topic is gingiva. Coming to introduction, we all know the normal periodontium provides the support necessary to maintain teeth in function. It has four components: gingiva, cementum, alveolar bone and periodontal ligament. Coming to the definitions of gingiva, Karansa said that gingiva is the part of oral mucosa that covers the alveolar process of jaws and surrounds the neck of the teeth. According to Lindsay, gingiva is that part of the masticatory mucosa covering the alveolar processes and the cervical portions of the teeth. Gingiva has both macroscopic and microscopic features. Coming to the macroscopic features, gingiva is divided into marginal gingiva, attached gingiva and interdental gingiva. Coming to the marginal gingiva, it is also known as unattached or free gingiva, which is a terminal edge or border of the gingiva that surrounds the teeth in a collar-like fashion. It is usually about 1 mm wide, demarcated from the adjacent attached gingiva by a shallow linear depression called the free gingival groove or marginal groove as shown in the picture. It extends on the enamel surface approximately 1.5 to 2 mm coronal to the CEJ. The gingival zenith is the most apical point of the marginal gingival scallop. Its apicocoronal and mesiodistal dimensions vary between 0.06 and 0.96 mm. Free gingival groove is located corresponding to the level of the CEJ and seen in about 50% of the cases. Coming to the gingival sulcus. A gingival sulcus is a shallow crevice or space around the tooth bounded by the surface of the tooth on one side and epithelium lining the free margin of the gingiva on the other side. It is V-shaped and barely permits the entrance of a periodontal probe. The clinical determination of the depth of the gingival sulcus is an important diagnostic parameter. According to Gottlieb B. et al. In 1933, normal or ideal conditions, the gingival sulcus is of 0 mm or close to 0 mm while probing. But in normal humans, the histological depth of gingival sulcus is 1.8 mm and clinical probing depth is 2 to 3 mm. Attached gingiva. It is continuous with the marginal gingiva. It is firm, resilient and tightly bound to the underlying periosteum of the alveolar bone. Its facial aspect of the extends to the relatively loose and movable alveolar mucosa, which is demarcated by the mucogingival junction as shown in the picture. What is the significance of attached gingiva? It supports the marginal gingiva, provides attachment for the movable alveolar mucosa for the action of lips, cheeks, tongue, etc. and withstand frictional and functional stresses of mastication and toothbrushing. It also acts as a barrier for passage of inflammation. Coming to the width of attached gingiva, the distance between the mucogingival junction and the projection on the external surface of the bottom of the gingival sulcus or the periodontal pocket is measured. It is seen greatest in the incisor region, that is in the maxillary region 3.5 to 4.5 mm and in mandible it is 3.3 to 3.9 mm. It is also narrower in the posterior segments. In maxillary first premolars it is 1.9 mm and in mandibular first premolars it is 1.8 mm. We can measure the width of attached gingiva through anatomical methods using probing, through tension test, roll test and Schiller's iodide test. Coming to mucogingival junction. It is an important landmark between the coronally positioned attached gingiva and the apically placed alveolar mucosa. It is absent on the palatal gingiva of the maxilla due to an absence of a freely movable alveolar mucosa on the palate. This mucogingival junction remains stationary throughout the life. Coming to the interdental gingiva. It occupies the gingival embrasure, which is the interproximal space between the area of tooth contact. It is pyramidal or cone shaped. The tip of the papilla is located immediately beneath the contact point. What is a cone? It is a valley-like depression that connects a facial and lingual papilla and that conforms to the shape of the interproximal contact. Coming to the gingival phenotype. What is gingival phenotype? It is the thickness of gingiva in the faciopalatal or faciolingual dimension. According to Seibert and Linde in 1989, it is classified as thick and flat or thin and scalloped. What is a thick biotype? Broad zone of keratinized tissue with a flat gingival contour which indicates thick underlying bony architecture, which is more resilient to any inflammation or trauma. Coming to thin biotype, it is a thin band of keratinized tissue, scalloped gingival contour which indicates thin bony architecture, and it is more sensitive to inflammation or trauma. According to 2017 World Workshop, the gingival biotype is changed to periodontal phenotype. It is determined by both gingival phenotype, that is the gingival thickness or keratinized tissue width, and bone morphotype, that is the thickness of the buccal bone plate. Thin phenotype increases the risk for gingival recession. It can be assessed by using a periodontal probe to measure the gingival thickness, observing the periodontal probe shining through the gingival tissue after being inserted into the sulcus. If the probe is visible, then the gingiva is thin, that is less than or equal to 1 mm. If the probe is not visible, then the gingiva is thick, that is greater than 1 mm. Now, coming to the microscopic features, gingiva has three parts: the gingival epithelium, the epithelium connective tissue interface, and the gingival connective tissue. The gingival epithelium is divided into oral epithelium, sulcular epithelium, and junctional epithelium. Coming to gingival epithelium, it consists of a continuous lining of stratified squamous epithelium. The main functions are mechanical, chemical, water, and microbial barrier, and it also has signaling functions. The major cell type or principal cells of a gingival epithelium is keratinocytes. Other cell types or non-keratinocytes are melanocytes, Langerhans cells, Merkel cells. Coming to the keratinocytes, their major cell constituent originate from the ectodermal germ layer. Differentiation occurs from the basal to coronal layers. Its function provides a sheet of epithelia that act as a barrier to cover underlying vital structures. It fills any breach in continuity as a result of physical or chemical trauma. It features numerous cell-to-cell contact, presence of contractile elements. It also consists of cytoplasmic extensions which aids in locomotion. They secrete antimicrobial peptides for defense called as defensins alpha and beta. The intracellular organelles are nucleus, ribosome, Golgi apparatus, melanosomes, and basal cytokeratins such as K5 and K14, and epithelial cytokeratins K6 and K16. Coming to non-keratinocytes, melanocytes are dendritic cells which are located in basal and spinous layers between the keratinocytes, which store melanin in organelles called the melanosomes. Langerhans cells are also dendritic cells located in all suprabasal layers between the keratinocytes, which contains Birbeck granules. Merkel cells have nerve endings which is located in deeper layers of epithelium, which are known as the tactile perceptors. Coming to epithelialization, factors affecting epithelialization are the epidermal growth factor and transforming growth factor, and keratinocyte growth factor and hepatocyte growth factor. Also interleukin 1 and TNF alpha. The keratinizations include orthokeratinization and parakeratinization, and also non-keratinization. To orthokeratinization, there is complete keratinization of superficial layer and no nuclei in stratum corneal layer. And there is also a well-defined stratum granulosum as seen in the figure. Coming to parakeratinization, intermediate stage of keratinization is seen. Most prevalent surface of the gingival epithelium, stratum cornea retains pycnotic nuclei as seen in the figure, and there is also presence of keratohyalin granules. Then what is non-keratinization? There are viable nuclei in the superficial layers as seen in the figure, and there is absence of stratum granulosum and stratum cornea layers. The layers of non-keratinization are called as stratum superficial, stratum intermedia and stratum basale. Coming to the proteins, they are cytokeratins, filaggrin, loricrin and involucrin. The cytokeratins are keratin protein found in the intracytoplasmic cytoskeleton of epithelial tissue. The basal cells contain K19 cytokeratins, while the stratum corneum contains K1 cytokeratins. The gingival epithelium is functionally and morphologically divided into outer or oral epithelium, sulcular epithelium and junctional epithelium. To the oral epithelium, it is a keratinized, stratified, squamous type of epithelium with a 0.2 to 0.3 mm thickness, covers the crust and outer surface of marginal and attached gingiva, which consisting of 4 layers. The layers are stratum basale, which is the basal layer, stratum spinosum, which is a prickle cell layer, stratum granulosum, which is a granular layer, and stratum corneum, which is why called that cornified layer. Coming to stratum basale, it is a cylindrical or cuboidal cells are contained, found immediately next to the connective tissue and separated by a basement membrane. It contains 2 types of cells, that is stem cells and serrated cells. Coming to stratum spinosum, there are polyhedral cells with short cytoplasmic processes are present. That's why it's also known as prickle cell layer. It is the uppermost cells from this layer contain granules called as keratinosomes or Odland bodies. Coming to stratum granulosum, cells are flattened and parallel to the gingival surface. Keratohyalin granules associated with keratin formation are round in shape and appear within cytoplasm of the cell. Coming to stratum corneum, they are closely packed, flattened cells which do not contain nuclei. Cells are densely packed with tonofilaments. Rounded bodies, probably representing lipid droplets, appear within the cytoplasm of the cells in stratum.